All right, guys. The lecture today, I tried to record it. It did not work. So this is part, or try to, I should say. And this is on postpartum complications. So we will kind of go through this and get you guys squared away for next week. So the biggest thing we're going to talk about is postpartum hemorrhage. And it is the leading cause of maternal death worldwide. 12% of all maternal deaths in the United States is associated with postpartum hemorrhages. It is traditionally defined as a blood loss more than 500 after a vaginal birth and more than 1,000 after a cesarean birth. It's important to know that this is what your textbook says. However, AWHONN and ACOG, which are the defining leading bodies of obstetrical nursing, now define any blood loss greater than 500 as more than it should be. It is a life-threatening condition with very little warning, and most people don't recognize it until profound symptoms have occurred. This graph here kind of gives you the layout of what causes a postpartum hemorrhage. You have the 4 T's, which are thrombin, tissue, tone, and trauma. And you can see under each one what kind of causes those things. So thrombin could be preeclampsia, it might be a bleeding disorder, tissue could be retained placenta, tone is could be a placenta previa or an distended uterus. Trauma is due to lacerations, episiotomies, or fetal microsomia. Then you have your other category there. The biggest ones you typically see are tone and tissue when we're dealing with a postpartum hemorrhage. So what risk factors do we have for people to have a postpartum hemorrhage? It is associated with multiple, lots of pregnancies, polyhydramnia, fetal microsomia, remember that's your large baby, a multifetal gestations, think twins and triplets, the use of mag sulfate, and that would be because it is a muscle relaxant. So what we need to do from last lecture you listened to is we need that uterus to contract, and if we have given them a lot of mag sulfate, it's a smooth muscle relaxer, so it doesn't want to work. Okay, overuse of pitocin during labor can also cause or increased risk for postpartum hemorrhage. If the placenta doesn't deliver within 30 minutes with gentle retraction, then they call it retained placenta, and retained placenta can definitely cause a postpartum hemorrhage. Placenta creta, remember that's when the placenta goes through the uterine wall. It makes sense that that could increase your risk for postpartum hemorrhage because as the placenta is trying to come off the uterus, it's grown into the uterus, so that could cause a problem. The gold standard for placenta creta is actually to have a hysterectomy. However, if this mom is young and wants to try to maintain her fertility, then the physician will try to remove the placenta and keep the uterus intact. Another cause can be the subinvolution of the uterus. Remember, that's when the uterus does not go back to the pre-pregnancy size. It causes late postpartum bleeding. This is typically, 24, 48 hours out. Remember, the cause of the subinvolution is usually a retained placenta fragment or a pelvic infection, but a retained placenta will cause that postpartum hemorrhage. So we need to look at how we're going to care for the postpartum hemorrhage. If you look at the picture there on your left, when we document bleeding for a postpartum patient, we document it as scant, light, moderate, or heavy. And you can kind of see the representation on the pads there. One of the things to kind of remember is if you're seeing moderate bleeding on a pad, it's good to ask the patient when the last time they changed their peri pad was. If it's been greater than 6 hours, then obviously that's not going to be a good representation of current bleeding. We always kind of want our patients to be in that scant to light amount, especially when we're doing a fundal massage. So our medical management is, one, we need to recognize, it's super critical for the early recognition of a postpartum hemorrhage. So your first step is evaluation of the contractility of the uterus, meaning, is the uterus firm? If you'll notice, there's lots of stars there. So that's always your first step. Decide if your fundus is firm or is it boggy. I always like to kind of say a firm fundus feels like a hard ball, and a boggy uterus feels like that deflated, half deflated rubber ball. It's kind of squishy. So you definitely want to assess for that. You got to decide, are we firm or are we boggy? Because then that can help you determine what might be going on with the patient. If it's boggy, does it firm up when you massage it? That's important, okay? So our first management is towards increasing the contractions and minimizing blood loss, as long as the uterus is the source of the bleeding. That's very, very important, okay? That's your tone out of your 4Ts. If you have excessive bleeding into a postpartum hemorrhage related to thrombin or trauma, you can massage that fundus all day long and it's not going to solve your problem, because the firmness is not the issue, okay? So if the loss of the uterine contractility is not the source, you're losing time by just continuing to focus on the uterus and continue to do that fundus massage. If the fundus is firm, you have to move on and try to determine where the other sites of the bleeding are coming from. However, if the site or the reason for your bleeding is the tone out of your 4Ts, these are some medications we can give. They give Pitocin, usually right after delivery. They'll get an IM injection of it to kind of help those muscles in the uterus contract down more. You can use it extremely liberally in an IV. You can give it and give it and give it. However, you need to be cautious that you could get into a fluid overload or a water toxicity issue. So you need to be careful how much Pitocin we're pouring into these patients in the IV, because remember, that's mixed in a 1,000 ml bag of fluid, and our cardiac patients could be easily put into fluid overload. Hemabate is given IV. The number one side effect of that is severe diarrhea, and they can have it for hours afterwards. You also need to make sure you know your patient's history. If your patient has asthma, this is not a medication you want to give them. So if your patient has a known history of asthma, you need to notify the doctor if he's ordering Hemabate. We can also use Methergin. It can be given IV or IM. You want to try not to use this medication in anybody who has a pre-existing hypertension disorder, because it causes hypertension. So we need to be careful with that. You can give Cytotec vaginally or rectally. It's a prostaglandin type drug. But remember, we also use it to help induce labor. They put it in the vaginal. We put it in the vaginal os, or the cervical os, when you're trying to soften to dilate the cervix. But after delivery, you can give it rectally, is usually how it's given, and it'll help some contraction with that uterus. The other medication I want to mention to you is called TXA, or tranexamic acid. It is a medication that can be given IV. It works for multiple reasons on those T's. The medicines that you're seeing on the screen right now, these are all used for a tone problem. But you can give TXA if you have a tone problem, you have a thrombin problem, You can even use it if you've got a trauma issue, because it constricts blood vessels down, so it can help slow the bleeding while you're trying to repair that trauma issue. And it's also, I don't know why more doctors don't use it as a first-line medication, because there are no contraindications for the medication unless you are allergic to it. So it doesn't matter if you have asthma or hypertension, you can use this medication. I do see it used more and more frequently, but it's never like the first thing. Everybody wants to use Pitocin first. But I am a huge fan of the TXA. So if we have that hypotonic uterus or a boggy uterus, we're going to start, your textbook says you're going to start with Pitocin. And if it's not effective, you're going to consider other medications, such as the Hemabate and the Metrogyl. But remember your contraindications for those two. Those are important to know. You also need to recognize that bleeding with a firm fundus, you need to move on. Look for the other source. Do you have a surgical laceration, a hematoma that's ruptured, vaginal laceration that, sometimes the sutures don't hold, or there is a laceration that the physician didn't see after delivery. So remember, move on from just fundal massage after fundal massage if your fundus is firm. You're not fixing the problem. Okay. You can also have a uterine inversion. This is what I was talking about when we were talking about doing fundal massages in the last chapter. That's why you need to support the lower segment, because if you flip the uterus inside out, they will likely need an immediate hysterectomy. And then we've talked about subevolution several times now. The number one reason for that is a retained placenta fragment. If you feel like that is what is going on with your patient, you've massaged the fundus, it's firm, you have closely inspected the perineum area as best as you can, and you're not seeing any bleeding from lacerations. And so now you're leading yourself down the path of a retained placenta fragment. The physician will come down, and you need to pre-medicate your patient with like morphine. This is going to be a very, very painful procedure for the patient. But the physician there at bedside will put their hand back up in this patient to the uterus and do a manual sweep of the uterus to try to remove any retained placenta fragments, blood clots, and all of that. It is extremely painful, so make sure you medicate your patient. We don't take them off to the OR because even though it's a painful procedure, if we can do it at bedside, it keeps the patient from having to have a surgical procedure and having anesthesia and all of that. So they will try to do it at the bedside. So what are our nursing interventions when we are thinking postpartum hemorrhage? So number one, we start with the fundal massage. Also, we've talked about multiple times making sure your patient's bladder is empty. If your patient is symptomatic of blood loss, dizzy, lightheaded, don't send them off to the bathroom. Just put them in bed and go ahead, and you can straight cath them to empty the bladder. They don't have to go off to the bathroom. You do not want that for safety reasons if they're starting to be symptomatic. Remember, if the fundus is firm, to move on. We need to do pad counts. We need to count how many pads the patient is bleeding through. And that's not just peri pads. That could be chuck pads, towels, whatever. And you really need to do quantitative blood loss. And how you calculate quantitative blood loss is, one, you have to know the dry weights of your objects. So if you're talking about a chuck pad, you need to know how much that chuck pad weighs. Then you can take the saturated pad and weigh it. You subtract the two numbers. The number you have left in grams, it has to be in grams, but grams will equal milliliters. Okay, so if we're just talking about some kind of small pad that weighs 50 grams, it's got blood all over it, we weigh it, now it weighs 75 grams. If you subtract those two, now you have 25 grams, and that would equal 25 mLs of blood on that pad. So that's just a kind of a quick brain math for me to tell you guys, but you know, you could have a check pad that weighed 275 dry and now it weighs 900. So obviously, if you subtract that out, you know, you're talking about what, about 575 mLs of blood loss, if my math's correct, but you guys see where I'm going with that. You need to do frequent assessments of the blood loss. Stay with your patient. Try to figure out the cause of your bleeding. You're going to want labs. You're going to look at an H&H. We always have mom's blood type, but we might need to get a cross match in case we need to do a blood transfusion. Go ahead and prepare for fluid replacement. And remember, when we're trying to do a volume expander, we always want lactated ringers in this type of setting. Lactated ringer stays in the in the vascular space. It doesn't leak out and go wherever like normal saline does. We want to make sure we have adequate venous access. So, you know, if she has one IV, we want to get a second one in, and hopefully a large bore one. If she doesn't have any IV access, go ahead and get 2 started. You need to anticipate a transfusion. If the patient starts becoming symptomatic for shock, go ahead and start her on oxygen. We're going to be doing vital signs. This PowerPoint says every 15 minutes, but sometimes we do it every 5. It just depends. Remember your signs and symptoms of hypovolemia and what those look like. And, you know, initially you're going to have an increased heart rate, decreased blood pressure, your O2 sats are going to go down, respiratory rate's going to increase, and of course your later signs are altered mental status or a change in level of consciousness. If you get into a change of level of consciousness, we are in a later stage of a postpartum hemorrhage and definitely in a later stage of the hypovolemic shock, which becomes very critical and could end with the patient losing their life. So when we talked about lacerations, we talked about that they could be on the cervix, the vagina, the perineum. Always start here next if you've done that fundal massage and it's nice and firm. Now we need to do a good vaginal exam and look. You got to be down there and looking, okay? Causes of lacerations can be a precipitous delivery, varicosities, which are basically varicose veins in the vaginal, like on the vaginal wall, the size of the presenting part relative to the size of the pelvis. When you think of this, just think of your microsomia babies, like great big babies greater than 4,000 grams. So you need to make sure that the suture or the repairs are intact, or make sure there wasn't one that was missed. Over here on this box, it talks to you about the different degrees of lacerations, and I know that Ms. Huffman kind of already talked about this during her lectures, but you need to realize you don't have to have it memorized. You know, first degree is vaginal mucosa membrane and skin of the perineum. Realize there's 4 different types. Obviously, they get worse. You know, the higher the number, and when you get to a 4th degree tear, that's all the way through the rectal sphincter. These moms who have a tear or a 4th degree tear will rarely have a vaginal delivery again, just related to the trauma of it. They'll opt for a C-section. But like I said, you need to start looking at the possibility of this if the fundus is firm. So you don't need to memorize this chart or this algorithm. However, I really, really encourage you to kind of read over it a couple of times because I think it's super helpful for you then to start understanding a postpartum hemorrhage. The green boxes at the top, you know, the first one obviously tells you we've got a postpartum hemorrhage, okay? Then the next 3 boxes kind of, as the nurse, tell you what you need to do. You need to assess and determine the source. We need to anticipate orders, especially your lab work, and make sure you have those venous accesses, okay? Then as you look at this graph, you know, on the far left, it starts talking about placenta and fundal massages, whether the fundus is boggy or it's firm, and then it kind of steps you down what you need to do. The pink section there in the middle talks about the placenta being retained. And your anticipate need for an anesthetic, aka pain medicine, get the morphine out. And then what you kind of do for that. And then what happens if you have a suspected coagulopathy problem. What are you going to do for this patient? So like I said, you don't need to memorize this. I'm not going to say, what's step 4 if we have a boggy fundus? But if you review it, I think it helps you understand what you need to do. So I really like this representation of a postpartum hemorrhage. I mean, there's absolutely no reason to die as a result of a postpartum hemorrhage caused by either the cervical laceration, perineal laceration, or retained placenta. These are extremely treatable as long as they are recognized early. Okay. Really, the only one that, that is the hardest to treat sometimes is the coagulopathy reason or the thrombin reason for a postpartum hemorrhage. Those are going to take a little bit more in-depth interventions, but these other ones should be easily treated as long as you recognize them early. Okay, your uterine acne should be treated. Sometimes it can be resistant to interventions, and this says dependent on the cause, meaning if we have had this mom on Pitocin for 10 hours of labor, her uterus is it's tired, it's wore out, it's just like I can't contract anymore. Okay. Also remember, if we give mag sulfate, that is a smooth muscle relaxer. So if you've given the mom a bunch of mag sulfate because she's preeclamptic, and now you're trying to give her Pitocin because of a hemorrhage, you've got two medications fighting against each other. So that's why it can be difficult. You also need to think about a late result of a postpartum hemorrhage, because postpartum hemorrhages will start snowballing, okay? And then it can lead into DIC, okay? Remember, DIC is when all of your clotting factors fail. So you're just bleeding everywhere. You can't stop it, nothing will clot. And it can end in multi-organ failure with a poor prognosis. So this is just a case study. We're the mother-baby nurse for this Miss Avery. You can see her GT-PAL 65015. She had a 9-pound baby boy this morning. Her perineum's intact. She's breastfeeding. All her lab results are normal. She's now 5 hours postpartum, and a family member calls out for assistance. You go in. She's standing in a pool of blood, and she's like, I don't know what happened. It just came on when I stood up, and she's dizzy and lightheaded. So what should the nurse's initial action be? We want to put her in the bed. She's symptomatic. She's dizzy, lightheaded. Get her in the bed so you can start an assessment. So, what 3 interventions, are you going to do as the nurse? Okay. Number 1, we're going to assess her fundus. Okay. See if it's boggy or it's firm. We're going to empty her bladder. And anytime you're doing a fundal massage, you should be watching the perineal area for blood. Do we have a trickle of blood? Do we have gushing of blood? Do we have clots just running out? So you need to be assessing that. And then what were this patient's risk factors for this hemorrhage? She's had a lot of babies. It was a quick delivery. It was a large baby, all those. And then what should the medical management include? Well, remember, we have to decide which of our 4 T's we're dealing with before we can really select our medical management, okay? If it's a tone, we've got lots of medications we can use, plus the fundal massage. If it's a thrombin issue, we might have to treat with specific medications for her problem with her clotting disorder. Also, remember TXA is really good. If it's a tissue issue, we've got to remove that tissue. Okay, and if it's trauma, we need to repair the trauma. So the other part of postpartum complications are your postpartum infections. Um, Puerperal, which just means postpartum. Sepsis is any infection of the genital tract within 28 days after a miscarriage, an induced abortion, or a birth. Your most common agents are streptococcal or anaerobic organisms. Your first sign is foul-smelling lochia with a fever to follow. Okay, look at that. It's highlighted. Your first sign of an infection in the genital tract is a foul-smelling lochia, and then they have a fever. Okay. Endometritis is it's an infection in the uterus. Okay. Your first sign of that is abdominal tenderness, and then you have a fever. Wound infections, we all know we can get infections in incisions, so it's important to teach perineal care to these moms who have lacerations or episiotomy, which include using a peri bottle, a mild soap to the area, and padding to dry. Urinary tract infections, often due to a Foley catheter during labor or a C-section. Everybody knows the protocols at the hospital is to get Foleys out as quick as we can. We don't want to leave Foleys in, and the same goes for these patients. Mastitis, that is an infection in the breast tissue. It's caused by a plugged milk duct. You usually have redness and soreness to an area of the breast with flu-like symptoms and a fever. Okay. One of the easiest things the mom can do to help, because you've got to get the duct unplugged, is to continue to nurse the baby, massage the breast tissue, but you're going to have an antibiotic because it is an infection. So one of the last things we're going to talk about is psychological complications in the postpartum period. We need to take the mental health of our moms very serious. When a mom has a mental health disorder in the postpartum period, it can affect not only herself, but the newborn as well as the entire family. It can interfere with the attachment to the newborn. It can threaten safety if it becomes severe enough. And this is safety for the mom and the newborn and any other children in the home if psychosis occurs. So you do have different types of postpartum depression. You have the postpartum blues, or you hear called the baby blues. You can see there on the diagram that 50 to 85% of mothers in the first 2 weeks postpartum suffer from this. Okay, these are mild negative feelings. You can have some irritability, anxiety, fluctuating mood, or an increased emotional reactivity. And what it means by increased emotional reactivity is if something is sad and makes somebody frown, it might make you cry. So you have just a little bit more exaggerated response. Somebody tells a joke that's mildly funny, you might find it so funny you can't quit laughing. Not necessarily because we're talking about depression, but I'm just trying to show you that it's an increase in that emotional response. Okay, the feelings are mild and spontaneous. They spontaneously go away. It's not considered a psychiatric disorder. I think studies really kind of just cough this up, so to speak, to the increased hormonal levels in the mom and the changes in the hormones. And once those hormone levels kind of settle, then these baby blues or these emotional symptoms resolve. Okay. Then you can also have postpartum depression, which happens in 13% of mothers in the first year. So within the first year of a mom having a baby, at any point in time as she's diagnosed with depression, it's labeled postpartum depression, always in that first year after delivery. You all had mental health last semester. this is depression. So you have the exact same signs and symptoms as anybody with depression. You can have excessive guilt, anxiety, depressed mood, insomnia, hypersomnia. You want to eat, you don't want to eat. You may have suicidal ideation. But focus on that is just suicidal ideation, which means you think about it, maybe the world would be better off if I wasn't here, but it's not something you act on. Okay, I can't tell you how important that is to kind of put that in your mind. You might think about it, but you do not have a plan and you do not act on it. You can also have extreme fatigue. Symptoms can be moderate to severe, and they can last for a very, very long time. So, mom can be diagnosed in that first year, but that doesn't mean that it'll go away within a year. She could be diagnosed with it when the baby's 6 months old, and, she might be treated for postpartum depression for years. You're not going to change it from postpartum to just depression because it was diagnosed during the postpartum period. Then you can have postpartum psychosis. You can see the statistic on that is extremely rare. 0.01% of mothers would develop this in the first 3 months postpartum. And remember, there's no hard rules to anything. Sometimes this develops a little bit later on in the postpartum period, but it's typically early on in the postpartum period. Now, the symptoms may worsen over time, okay? But this is the patient who has mixed or rapid cycling. Think how people with bipolar disorder act. They're agitated very easily. These patients start having delusions and hallucinations, okay? So they start thinking it'd be better off for me not to even, it goes beyond the suicidal ideation to they have a plan, okay? They have a plan to hurt or kill themselves and their children or the newborn, okay? The hallucinations might tell them this is such a terrible world, you don't want your baby growing up here, you need to, make her an angel, something like that. It's a delusional thought process with hallucinations. It's disorganized behavior. They don't know that what they're thinking is not rational, okay? It's like a psychotic break, okay? It's very severe. It's considered a psychiatric emergency, and often these patients will need hospitalization for, not forever, obviously, but it's going to be more than that. You think about that 3-day hold people get on, it would be longer than that. So when we're discharging these moms from the hospital, whoever their significant other is, we need to educate them as well about, watching for these severe symptoms. Because like I said, mom's not going to be able to recognize it and go, oh crap, I need help. So somebody else needs to be aware of the signs and symptoms, so if they see them, then they can get the mom the help that she needs, which, like I said, it is in a psychiatric emergency. They need to be brought immediately, at least to the ER for treatment. So when we're talking about postpartum depression without the psychotic feature, so we're just talking about straight up postpartum depression, remember, it's intense and pervasive sadness with severe and labile mood swings, just like any type of depression. So what is our medical management? We can use antidepressants, mood stabilizers. There are cases in treatment that are appropriate to use electroshock therapy. Most of your antidepressants are not safe during breastfeeding, but you always have to look at risk versus benefit. If this mom is suffering from severe depression that she needs medication, that's going to outweigh her need or want to breastfeed. Okay, so she might have to switch to bottle feeding. There are a couple of antidepressants that are relatively safe for breastfeeding, so that's always an option they can look at. That's something that the mom and the doctor will have to decide on. You can also do therapy. to, work through and talk through what her fears and concerns are. And we always want to monitor for those suicidal or homicidal thoughts. Make sure that our depression is not worsening. And then you have your postpartum psychological complications or the postpartum depression with psychotic features. Okay. You still have that depression, but remember we have delusions, and you have to remember, I can't say this enough, I can't stress this enough. This is when you have the homicidal and suicidal plan. We went from I wish I was dead to I know how I'm going to do it. You have to realize the differences between just postpartum depression and what turns it into psychosis. Okay. Once again, it's an emergency. It is associated more, like I said, it's a very small percent of population who develops this disorder, but the ones who do tend to already have a strong mental health background, and a lot of times it can be associated with bipolar disorder. So what can we do for these patients? First, we need to start screening for postpartum depression. A lot of the hospitals now are having the nurses do a postpartum screening right before discharge. I think this is a fantastic idea. However, the questionnaire that they're using, and it's developed by the American Academy of Psychiatrists, or whatever their division's called, but it starts talking about, the questions are all about, how did you feel about this or that in the last 7 days? Well, unless, something has went wrong with the delivery, your last 7 days being pregnant, are usually a good time. You're excited, you've got a baby coming, and all those kind of things. So I think it's great to start having that conversation and doing a screening process, but I'm not sure that the screening process that's currently in use kind of fits the need. However, lots and lots of OB doctors here in our community are becoming very supportive and aware of mental health issues with our moms. So a lot of them are having the moms come in 1 week postpartum for just a mood check appointment, see how they're doing. And I think that's fantastic. Pediatricians are starting to kind of screen moms for depression while they're doing checkups with the newborn, and I think that's fantastic as well. Nursing care on the postpartum unit, advocate for your patient. If your patient has a history of postpartum depression, she's probably going to get it again. Statistically, it's very high. So go ahead and talk to that physician, especially if mom is willing. Maybe she needs to go ahead and be put on an antidepressant before discharge. Okay. We can also refer moms, to support groups and all those kind of things. Always assess for the safety of the mom and the baby. It would be very rare to manifest any kind of psychotic symptoms, in the 1 or 2 days that you have them on a postpartum unit. However, we had an incident just last fall that the baby was only 2 weeks old and mom developed psychosis and killed the baby. And that's right here in our communities, right here, that happened. So, definitely educate the caregiver on symptoms that need to be watched for. And we've talked about that they might need psychiatric hospitalization, psychotropic medications, and psychotherapy. So if we're looking at this case study, we have a mom who resulted or had a pregnancy from in vitro fertilization. It was an uncomplicated C-section 48 hours ago after a failed induction and a super long labor. APGAR scores are 9 and 9 for the baby, breastfeeding, but baby's sleepy at the breast and now has an elevated bilirubin, which means the baby's jaundice, and this states it's going to go home with a Billy blanket. There's been family involved with many visitors since the birth. You as the RN come in now to provide some discharge teaching. Your patient, she breaks down, she's crying, and she says, I'm so exhausted. This just hasn't worked out how I imagined. I feel so overwhelmed. So you need to think about things that you would say to her and suggestions that you make. What would be your care plan for this patient? What do you think happened during pregnancy and delivery that could increase her risk for postpartum depression? It was an IVF baby, so she struggled a long time probably to have a baby. She struggled with fertility. People, even though they fought for years and years and years to have this baby, sometimes their emotions are a little out of whack when the baby actually gets here. Like, do I really deserve this? You know, those kind of things. She had a really long labor that ended in a C-section. A lot of moms who do that, they start feeling like a failure. These mommy groups on Facebook just feed into that. I always advise my patients to stay away from those groups on any kind of social media, because most of the time they are not medical professionals. They are just talking about their own experience, and I get so sick and tired of the mommy shaming. Everybody's experience is their own, and it's their own individual. So you have to watch for that. Um, this patient has had nothing but visitors. She's been breastfeeding, but it hasn't been the easiest because the baby's sleeping or is sleepy, which means mom is sleep deprived. All of these things can barrel this mom into postpartum depression. So we need to be supportive of her. Things you can do as the nurse, you can have all the family leave the room for a while. Say, you know what, I'm going to do some teaching, and I need mom's full attention, so you guys can go to the waiting room for a little bit. You could offer the mom to take the baby to the nursery for just a little bit, so she can take a good nap before she goes home. Make sure you let the significant other know the importance of, you know, being a support system for her at home, and, you know, helping out and doing those kind of things. Okay. So the last thing we're going to talk about is fetal death and demise, a stillbirth, newborn death. Okay. Um, Before you can go in and help a mom who is dealing with this, you have to kind of deal with your own feelings about neonatal death. Um, and this is not the place to bring out your suggestions or what you would do. Just kind of put those feelings aside, okay? Um, don't impose your way of grieving on a mother or be critical of how she may be grieving. People grieve in different ways, they're in different stages of the grief process. Um, they may be in such disbelief and shock that mom may not be crying. Okay, that doesn't mean what she's doing is not appropriate. She's, you know, dealing with it the best she can at that moment. So you need to respect their choices. Okay. It's important to offer the opportunity to see and hold and touch the baby, spend time with the baby. Um, Even if the baby doesn't look, you know, as this, you know, quote unquote presentable, you can always wrap the baby in a blanket, put a hat on it, and let her have time with her baby. At Women's and Children's, we do have what's called a cooling crib now. That way, the baby can literally stay with mom pretty much as long as she wants. Every few hours, the baby does have to be put back into that cooling crib to decrease the temperature of the infant again, because of the decay process at room temperature. So, um, allow the family all the time they want, grandparents, siblings to come in. They need to realize that this baby, even though they're not taking it home, will always be a part of the family. So it's important to encourage them maybe to name the baby. Okay. If the baby is born and takes one breath, you would have a birth certificate, so they do have to name the baby. And then you would have a death certificate. If the baby is born stillbirth or a fetal demise, so we have no life at the time of delivery, then it's just a death certificate. Okay. Family might ask you about funeral homes. You can have funerals, obviously for your baby, so you can make arrangements for that. If they don't want to hold or see the baby, the staff always make sure to take pictures and footprints. We try to get handprints, and we kind of keep them in a file, because even if that family doesn't want, they're just so devastated, obviously, by the loss of their child that they just can't fathom that kind of stuff. We do that because inevitably, a month, 2 months later, mom calls. She's like hysterical, crying. And begging that we have pictures of her baby. And then we do. So then obviously we provide the footprints and the pictures and things to that family so that they do have those mementos of their child that they lost. Okay. You may need to do a bereavement consult or talk to them about support groups. After everything is said and done, the infant goes to the funeral home or something like that, they actually try to discharge the mom home if possible. It depends on her medical status, obviously. If she needs to stay in the hospital, we are not going to transfer her or move her down to the postpartum units where she has to walk past the newborn nursery or hear babies crying and all of that. That's just kind of cruel. So we would move her to another unit in the hospital that does not have infants. Like at Women's and Children's, we move her to the 3rd floor, which is the gynecology floor. So to try to be, empathetic and sympathetic of the situation they're going through, it's not appropriate to put them on the postpartum unit. So just in general, so if you're looking at this question, the most effective and least expensive treatment for that genital tract infection is prevention. What is important in this strategy? We want large doses of vitamin C during pregnancy, prophylactic antibiotics, strict aseptic technique, including hand washing by all healthcare personnel, or limited protein and fat intake. And so if you look at the question, it's saying the most effective and least expensive. So when you look at your answer choices, it's always going to be your strict aseptic technique with hand washing, okay? And that's also teaching the mom perineal care. The first symptom of a postpartum endometritis, the nurse is likely to see first. Looking at those 4 choices, and remember, it's asking you your very first symptom, and that would be your abdominal tenderness. Okay. I hope this video helps you guys. Please feel you can reach out to me. I can't talk. I'm sorry. I'm getting tongue-tied. I've been talking for 6 hours now. Feel free to reach out to me if you have questions, or jot down any questions you might have, and we can review them Monday. Okay? And that's it, guys.